My name is Father Trent Moore. I'm the assistant priest here at St. John's. I'd like to welcome all of you to the Sacred Conversations series throughout the series of Lent, or the season of Lent. And this is a place where we want this to be a sacred place for differing opinion. We welcome differing opinion. Our short history of that in the Episcopal and Anglican Church is Elizabeth I is the person who gets the credit for coming up with an approach to conflict called via media, the middle way. And the Episcopal and Anglican Church are known as the Church of the Middle Way, which means that we always seek common ground in those topics that just can't seem to be agreed upon. In our baptismal covenant, it says, with God's help, we seek to serve other people while loving our neighbors as ourselves. We strive for justice and peace among all nations, and we respect the dignity of every human being. Out of those lines were born this series, Sacred Conversations, which St. John's has been doing for many years now. And it's a great opportunity in such a polarized society, especially with some of the topics that we're dealing with, to look for common ground and to meet in the middle. And to do so prayerfully and thoughtfully. I've got some guidelines for our time today. 1, let's listen, really listen. 2, let's be respectful to one another. And 3, when we respond, let's do it out of love. And number 4, if you, towards the end, after all of the panelists speak, you'll have a chance to ask questions. Please join me in a prayer. Bless us, O God, in this holy season in which our hearts seek your help and healing. Purify us by your discipline, that we may grow in your grace and in the knowledge of our Lord and Savior, Jesus Christ, who lives and reigns with you and the Holy Spirit, one God, forever and ever. Amen. Today's topic, if you didn't know, is healthcare. And we have a very distinguished panel of guests. Thank you all for being here and giving your time to this. And without further ado, I'll turn it over to Liz Masick, who is on the board of St. John's Medical Center, as well as a parishioner here at St. John's, and she will introduce the rest of our guests.
Welcome. Thank you, everyone, for coming. Normally, I just get up and talk, but I actually wrote an introduction today because I tend to wander. And we have worked really hard on trying to narrow down this topic because it's so huge. So here I'll go. Last year, in collaboration with Teton County Public Health and many other community constituencies, we completed the Healthy Teton County Community Health Improvement Plan. This plan provided our community with a comprehensive overview of the primary health needs of our citizens. At this time, we are in the process of developing and executing community-wide strategies for impacting our local health needs as identified by the plan. Number 1 on the survey was access to health services. Oftentimes, we think of access to health care as meaning who has insurance or who doesn't. And while this is often a very important part of what access means, it is just one small piece of a much larger, complicated healthcare equation that as we know as healthcare in America. The best thing about the ACA, or Obamacare, if you like, is that it is pushing a fractured system to become much more efficient. Like it or not, healthcare providers are moving toward what we call the volume to value equation. What this means is that healthcare will move from treating disease to treating the whole health of individuals and communities. And the reason this is good news is because instead of a sick system that is dictated by ill health, it will now be a system based on keeping people healthier. As I like to say, duh. Part of this equation is that the reality of health has only about 20% to do with what we consider the doctor, hospital, pharma, medical side of the equation. Determinants of health care have much more to do with, and this is a definition by the World Health Organization, the conditions in which people are born, grow, live, work, and age. And lastly, the best part of this equation is that you, patients, caregivers, community members are empowered to take charge of not only your lifestyle choices, but also being part of the equation of the best care possible. So on that note, I would like to introduce today's panel. Vida Sanchez is with El Puente, and I'm going to let each of them, they wear so many hats in this community, I'll let each of them also talk about what they do, their bio, so to speak. And Dr. Hochheiser, the CEO of St. John's Medical Center, and Julia Heemstra, who is the director of our fast-growing wellness center. So on this note, I'll hand it up to Vida.
Hello, is that a good volume level? Okay, excellent. I'm Vida Sanchez, and I'm the founding director of El Puente. El Puente means the bridge, and we're basically a healthcare access organization that serves the Latino population here in Teton County. I haven't gotten out a whole lot in the last 12 years since we opened El Puente, so I'll just tell you a little bit about myself because I don't know if many of you know me. I trained to be a midwife on the U.S.-Mexico border, and from there came back to Teton County, Jackson, about 17 years ago. My family's lived here for about 30 years. And I came back, I happened to come back from the border right at the same time that the Latino population was booming here. Immediately got involved in interpreting, and the difference between interpretation and translation is that interpretation is all an oral rendering of a message from one language to another. Immediately got involved in interpreting in deliveries and prenatal visits, etc. Was struck by how difficult it was for some members of the Latino population to get the health care that they needed at that time. We set out to take a closer look at that, did a very grassroots needs assessment, and the results of that needs assessment led to the development of El Puente. We currently provide language access services, medical financial guidance services, and 2 women-focused programs. One's a family planning navigator, and the other is we coordinate the prenatal entry program, which I'll tell you more about in a bit. And we serve about 2,000 patients each year and provide over 9,000 hours of service. I'm very happy to be here today. I'm extremely passionate about the work that we do, and I'm really happy to be able to share some of that with you all. Back to what Liz was mentioning, I really would like to talk about the difference between access to care and a more inclusion-focused approach. As Liz was mentioning, we as a community finished the needs assessment, and I still think we're working on coming up with a well-articulated definition of what we mean by access. Oftentimes, we do mean, as Liz was mentioning, we tend to talk about whether or not a service is affordable, whether or not it exists here in Teton County, et cetera, et cetera. So to talk a little bit more about what I mean by the difference between an inclusive approach and an access approach, I'd like to just kind of paint a picture of a potential St. John's Medical Center, El Puente, Teton Free Clinic patient. So we have here, imagine a fellow, Julio, 39-year-old male. He's from rural Mexico. He's lived in Jackson for 7 years. He lives with his wife and his 15-year-old son who goes to Jackson Hole High School, and his 12-year-old son is at the middle school. He works in construction and makes a pretty good living at $21 an hour. His wife doesn't work. Both his parents are diabetic. His grandmother died of complications associated with diabetes, and now he thinks he might have some of the symptoms that he remembers his parents talking about. But he's not sure. It might just be related to stress, since his rent just went up by $450 a month, and his son's not doing too well in school. He knows that his wife knows a lot more about how to navigate through the healthcare system, but he doesn't want to talk to her and worry her any further. He's not really sure if he has any real issues to speak of. He knows he doesn't have too much extra money. He's uninsured. He knows he could always go to the emergency room, but he knows it's the most expensive choice. Thank you. That's a little pat on the back to Puente. He knows about the free clinic. but he fears that he'll see family members there because of the waiting room situation. He's too embarrassed to go there. And so he has never been to the doctor before in Jackson. What do we do with this potential patient? So we can see that in this patient's case, the care that he needs does exist. It is potentially affordable, and if it's not affordable, there are probably some mechanisms in place to help improve that situation. So in terms of your basic access questions and this patient, those are not the most pressing issues for this particular individual. So what adjustments as a healthcare system here, a local healthcare system, can we make to assure that this patient doesn't put off pursuing his issue for 5 years and end up in ER with high blood sugars, for example? So as a partial answer to that question, I'd actually like to share another story with you about a local, very successful, and what I mean by inclusion program, called the Prenatal Entry Program. This program is a program of St. John's Medical Center, the foundation, and has been in operation now for about 5 years. When the recession first hit, we saw 6 of our Latina patients deliver at St. John's Medical Center having received no prenatal care at all. And there were not, 5 of those 6 had some less than desirable outcomes. In response to that, our community came together and created a method by which we could assure that patients got into prenatal care when needed, and that no patient would deliver with no prenatal care at all here in Teton County. The collaboration was between St. John's Medical Center, Teton County Public Health, all of the OB providers, and Puente. And since that time, we've seen remarkable results, and we've had one person delivered with no prenatal care who arrived here on a Friday afternoon and delivered over the weekend. Aside from that, we've seen 100% success in that regard. And then we've also seen excellent numbers in terms of who's entering prenatal care early and getting the care that they need. So this system, basically what we did to create this very successful intervention was really just a correction on an existing system. We just made a slight adjustment based on a very accurate understanding of what the root causes of the issue were, and then aligning our intervention very well with the root cause issue. And one of the key factors there is the way that the community provider side really banded together around a common cause, and through that collaboration and harmonious collaboration, we were really able to very rapidly address an emerging healthcare access issue. So to me, that's more of an inclusion approach. We use our existing system, corrected in ways that it needed to be corrected to assure that everyone in our community was able to gain access to the existing high-quality services that we have here. So that's where I hope our conversation regarding healthcare access continues to go, towards more of an inclusion approach where we look at which groups are challenged, like our friend Julio here, to get the healthcare that they need, and just adjust our system appropriately. So we are back to our friend Julio. Do we have any activities in place right now to help do these system adjustments that are necessary to assure that this fellow gets the care that he needs? And I would say happily that we do. We have collaborations ongoing that are picking up momentum and speed to help us to, again, identify where we might have some healthcare issues in our community. For example, one of the handouts doesn't very clearly identify where this data came from, but pieces of it are from the assessment that Liz mentioned, and then also from Jackson Hole Compass, Jonathan Schechter's publication. You can see that our community does face some significant health disparities along ethnic lines, where we look at the different rates of insurance levels among adults between non-Latinos and Latinos. And then you can also look at Teton County free clinic data to get a sense of another health disparity that we're looking at, which has to do with the rates of type 2 diabetes among Latinos. And I believe that we are on the right track in terms of some of the programming that we're developing, and I won't go into too much detail because I think I'm already going far over my 5 minutes here. We're looking at, again, applying this inclusion approach where those of us, some of who you see sitting here, some are out here in the audience as well, Teton Free Clinic, as well. We're looking at how we can create a program of higher support, essentially so that someone like Julio has an easy way of being escorted through the healthcare system and is able to get the care that he needs. You'll probably over the course of the next few months hear more about those kind of activities. And the issue, the disparity related to insurance levels, that's also been an ongoing conversation for years. And we have several mechanisms and tools in place that help to ease some of the burden and the disparity basically created by that dynamic. So do we have vulnerabilities here in Teton County related to particular groups not being able to get all of the healthcare services needed? Absolutely. Do we also have pretty incredible efforts in place that have momentum and moving forward to look more closely at that? Yes. And again, I would really encourage from my last few years of experience for us to focus very closely on the success that we can accomplish through very well coordinated system side approach that is very careful about identifying what the real true issue is. For example, with our example patient here, Julio, one would potentially look at that situation and immediately say, well, he just can't afford health care. It's like, well, that is a piece of the issue, but that's not the real, ultimately, the only piece of the story. So as we all come together and continue to address our vulnerable areas, I hope that we can do so in this inclusive spirit that I think we've demonstrated can be very successful. Thank you.
I think I have one. Is this the correct volume? Excellent. Well, my name is Julia Heemstra. I've been living here in Jackson for 12 years, and I've actually been involved in prevention work in some manner or another since I moved to Jackson. I started off working for the Currency Foundation, doing contract work in the school district, teaching substance abuse prevention classes, and then moved on and worked for the Wyoming Department of Health for a number of years, and now have been at St. John's for over 5 years. I now am the director of the Wellness Department. We have grown very significantly in a very short period of time. We wear all kinds of hats in the Wellness Department, and I'm fortunate to have an absolutely incredible team that works with me. But one of the hats that we wear is pretty much putting together the community health needs assessment, very much in partnership with Teton County Public Health and the collaboration of over 35 35 different organizations in this community. And that was really landmark, because in the past, community health needs assessments had been done with a smaller amount of involvement from the community, and so we were so fortunate to be able to really rally that number of people and organizations to participate in this current iteration of the community health needs assessment, which did identify access to care as the prioritized health need in the community. And what was great was that it was actually prioritized by the 35 different organizations that participated. It wasn't that St. John's or Teton County Public Health just unilaterally decided that this was the issue. It was something that the community really saw as the primary health need in this community. I do just want to make a note that there were 3 indicators that we used when we identified access to health services or access to care as the primary issue. And those were uninsured adults, uninsured children, and the cost of a primary care visit. But as we all very much understand working in healthcare, access to care and access to health services is so much more than those 3 indicators. But that kind of leads me into what I'm going to focus on today, because another one of the hats that I wear is heading up St. John's involvement with the Affordable Care Act navigation in this community. And if you are unaware, we've actually been noted by the state for our work in this community, and they actually see it as the gold standard that they're hoping to duplicate throughout the rest of the state. And I really credit that to, again, the partnerships that we've had in working with the Affordable Care Act. Our primary partnership has been with Teton County Library, and early on they actually came to us and said, we really want to work with you on this. We feel like this is a very, very important issue to educate our community on. So together with Teton County Public Library, we put together a navigation program, and I've been fortunate to not only head it up from the St. John's side, but also to work as a navigator pretty much from day one with the ACA. And very often I look back on those times and I actually realize that they have been some of the most rewarding hours that I've had. Truly, there is little like working a person through the system and actually having true success, and having a person who previously has not been insured be insured and have access to the kind of care that they really need. I do want to make note that Teton County has actually had the highest level of enrollment in ACA from the very beginning, and our numbers from last year are pretty astounding, because we had 2,722 enrollees, and the second place finishing county was Laramie County, which has a population that's actually over 4 times that of ours here in Teton County, and they only had 2,580 enrollees. So it's pretty astounding that we had as high numbers as we did. I always make a note, though, that we also had the highest uninsured population here, so that was working to our advantage. There are definitely success stories with the ACA, and I feel like what we hear so often is all of the problems with the ACA. The vast majority of people that I've worked with, the system has worked well for them. The people that it works best for are people who are young, under the age of 40, people who are US citizens, who have an income under 400% of federal poverty level, and also, interestingly enough, have done their taxes on time, which astoundingly not that many people do their taxes on time. I know, appreciate that. But if you've not done your taxes on time, then you basically are not eligible for subsidies until you reconcile your taxes with the IRS. For those folks, we see significant subsidies, and I've actually worked with numerous people who have had premiums of $0 per month. That means that they're not paying anything for a premium, a deductible of around $100, that is, and then a max out-of-pocket of around $650. So that is really affordable. The other great thing about the ACA plans is that they now have preventive services covered at 100%, not subject to the deductible. So those are huge steps that we've taken in what I believe to be the correct direction. There are challenges, though, and those are some of the most heartbreaking cases that I've worked with. Again, these are the minority of clients, but we have a really unique situation here in Teton County in that most people make close to 400% of federal poverty level. And as people age, they tend to get even closer to 400% and sometimes over 400%. The most challenging cases that I worked with this year, aside from the people who fell into the Medicare gap, were older Teton County residents between the ages of 50 and 65. Keep in mind that 400% of federal poverty level is $63,720 for a couple. It's really hard to live here in Teton County, I would argue, as a couple at under $63,000, particularly if you are advanced in your career and you've been living here for quite some time. And so most of the people that I worked with were over 400% of federal poverty level and not eligible for subsidies. And it wasn't uncommon to actually be looking at premiums of close to $1,500 to $2,000 per a month for those individuals. So those were really, really tough cases. It was people who had chosen to retire a little bit before they were eligible for Medicare, or were self-employed, and their husband was also self-employed, so they were not eligible for insurance through their employer. Other heartbreaking cases, undocumented parents who have eligible children, where they are making too much to be eligible for Medicaid with that child, and also ineligible for kid care chip, just because we tend to have higher salaries here in Teton County. And what we found was that there were glitches in the system this year, and so if you were just signing one person up, one child under the age of 12, but you had a family of 5 living off of an income, the ACA Marketplace was pretty much allocating the entire income of that entire family to that one 12-year-old child, and so the 12-year-old child was not eligible for subsidies. Those were glitches that we escalated with CMS. We're still working on some of those cases right now, and hopefully those subsidies will be reconciled. Honestly, as much as there are successes with the ACA Marketplace, there is no easy answer for that particular population of older Teton County residents. I think about this a lot. Some ideas that we've kind of bandied about would be the idea of a premium assistance program, but then again, where do you start that? Where do you stop that? And again, it's something that is pretty unique to Teton County because we do have such high incomes here because we have to because of cost of living. I do think that we've come far with the ACA. I anticipate that we can go even further, so I'm interested to see where that's going to go.
So I pulled the H card so I could go last. I'm not sure how much you realize how spectacular the person on my right and the person on my left are, and their contributions to this community. Really unique, both in very different ways, but their commitment to what we need to have done has taken areas to a different level. If we could only kind of put them through, we've got these printers now, 3D printers, right? So we're going to create a few more of them, and then we'll solve all the problems that we have. As stated, I'm Hochheiser, and I've had the privilege of leading St. John's Medical Center for the past 4 years. Moved here because of a doctor's mistake, believe it or not. A very good mistake in the end. They told my daughter that when she was 33 weeks pregnant, she was going to have a preemie, that she was in labor. And my wife said, I'm going to help Annie. Are you coming? I came. And it turns out that Annie and I walked 4 miles on the dike at 42 weeks before she went in to be induced. So she never had a preemie. But we did come here, and we were here for 7 weeks, and we never left. So this certainly wasn't in my plan to be doing what I've done for the last 4 years, but some of the best things in life come without planning. And it's been really been my pleasure. So I'm going to take a much higher level, but I think the examples of what we've done in the community, whether it's the ACA or the prenatal program, are really pretty unique examples. And we have the luxury of being a small community where we can do some things, gather people together and make changes. And as Vida pointed out, it's really up to us to move things from access to inclusion. And the way you do that is not by looking at the whole big program because it's too daunting, but to pick out the areas that you can really make a difference in. And there's a number of other examples in the community. But some of the barriers to care are really how complex a world we've made healthcare. When I was a little tyke, living in Brooklyn, my parents had my primary care doctor, my family doctor. And he went so far as taking my tonsils out on the kitchen table in my home. Now, I'm not necessarily recommending that, but the idea is we went from a very simplistic system to a very complex system where you got to go through multiple systems, check your insurance, check all these other things to be able to get access to care. And if there's anything, it's the complexity that I'm concerned about, and increasing complexity. So the ACA has given us some really good things, but you need a navigator to get into it. And it's actually getting more complex as the rules and regulations come down. And, the biggest challenges to St. John's Medical Center is every day there's another set of rules that are coming down from the federal government and some from the state government. So I'm not sure how we deal with that, but it really is a major problem. The other piece that's really important is that 50% of what we deal with in medicine has a behavioral, and that's a modest number, have a behavioral component. And we are set up to separate out the medical from the behavioral side. And that, in our community, has some good parts about it, but also we never really put it together. And it's a challenge for us for the future. If you're going into the system, and I have this happen on a regular basis, somebody calls me up, I have X problem, and I went to Dr. A, and he said, this is what you should do. And somebody told me to go see Dr. B, who they knew, and she gave me a different answer. So I went to Dr. C, and I got a third answer. Can you help me sort this out? And we don't have a good way of sorting that out, because medicine isn't what we all would like. It's very clear. Here's the symptoms, here's the diagnosis, here's the treatment, and on we go. And you're better, and that's all it takes. But that's not the way medicine works. Every one of us is an individual, and if I don't listen, and Father said this morning, before we started, is to listen. And if I don't listen as a physician carefully, if I'm not sitting there just focused on you as the patient, and now of course we have that computer sitting at the physician's side, so we are automatically diverting attention. But I don't get the nuances of what you're saying, or I miss a question that could be very poignant. I can't tell you how many times that I've stood up, shake a hand on somebody who's walking out the door of my office when they say, oh, doctor, I forgot to tell you. And 9 times out of 10 is, I forgot to ask the question that was going to get the information that could make a huge decision. I've come to the conclusion that the state isn't going to solve our problems. The legislature is proving that once again. The federal government isn't going to solve our problems. And so we as a community, and I think St. John's has been a leader. I have to thank them for, I probably wouldn't be here if they hadn't had the foresight 100 years ago to start a hospital. And this is our 100th anniversary, and we have St. John's to thank for that. So we need to go the next step as a community, build on what Vida and Julia have been doing. Pick out different areas, and I would focus a lot on mental health and how we coordinate that with the medical system, and come up with our own solutions, whether we're talking about Julia, or we're talking about those of us who are aging and need some answers as things go on, or that 55-year-old people who are having struggles with getting some health care coverage that doesn't cost them $2,000 a month. That's it.
Okay, we have about 20 minutes, 15 minutes left. Before I move it to the audience questions, did any of you want to ask one another a question or pick up on any of your... One thing I wanted to add with Julia's point about people who fall outside of Medicare or Medicaid but don't qualify, not only is it that $1,500 to $2,000 a month deductible, but then they have a, what, $6,000 to...
Yeah, I would say oftentimes when I'm looking at premiums that are around $1,500 to $2,000, we're also looking at deductibles that are upwards of $10,000. And the other point that I actually think is really important to keep in mind is that when you look at when chronic diseases and chronic conditions start to manifest, that's often exactly in this age bracket. So when I'm sitting with people who are in their 50s and 60s, oftentimes they know they need care. They already are receiving care, and they're looking to find a way that they can continue to receive care so that their condition doesn't escalate, so that they're actually an inpatient at St. John's.
Okay, any questions? I know we have lots of questions. We won't let you not ask them. Let's just start here and go across the room. Do you want to go to the mic? Thanks, Mom.
Vida, like your guy, Lulu, do most of you, the people that you see, are they undocumented or do they have permanent resident status?
Depends if we're talking about adults or children.
Adults.
Okay. With adults, at El Puente, we don't necessarily require information on immigration status. And there's a full spectrum, but most of our clients are not eligible for ACA marketplace participation, for example. So that means they don't have the documentation needed for that. There's a list of different types of visas that are required for that, but primarily, yeah, permanent residency or naturalized citizens. So I don't have a number for you, a hard figure, but I would say, yeah, we definitely have many undocumented adults who struggle to figure out how to be included in our local healthcare system.
I'm curious about the focus on mental health, and where do you think, what do you think are the next sort of frontiers for this community in that area?
So we actually are pretty fortunate when you look around Wyoming that we have more mental health here. Our community counseling center is an excellent place. Takes all comers. They keep getting less and less money from the government every year, and so, but we have a really good group of counselors who really work for far less than they're valued, even compared to other jobs in this community. I happen to know that because my wife was there for 9 years. But what I think we lack is we have a lot of pieces, and I'd like to see us bring in somebody who's tasked for community psychiatry, community mental health, to say, we have a responsibility for our county. How do we put it all together? Somebody can work with Vida's organization. Somebody can work with Mary's organization. Somebody can say, boy, this is the direction we ought to be going. That has credibility with our counselors, credibility with the private sector, to say, here's a system we're going to develop that works with the primary care doctors. Here's a system. And that's kind of, I don't know if I can get it done before I leave, but it would be a nice thing.
As a follow-up, do you think like an acute care, inpatient care component might be added to our excellent, outpatient availability of services?
That's a tough one because it costs a lot of money to have an inpatient psychiatric facility. Now, if the state were to decide to disperse its facilities and say for not only Teton County, but they said to Fremont County, for Suffolk County, Lincoln County, we'd have a facility, then you could have a small facility that could provide comprehensive services close to where people live so that their families can participate in their needs when they have an inpatient need. That would make some sense. But right now, the state's thinking is, how do we spend less money and keep everybody in certain places? And we have all these empty beds, but we're not funding them. So that if we have a patient who gets admitted, and we admit patients with psychiatric problems who are entitled or not even entitled. Entitling means that they are in against their will because they're a danger to themselves or to others. But then we put them in a locked room. And, you don't put a person who's having psychosis in a locked room. And then it takes this complex legal process where they have to go through. They can be there sometimes as long as 20 days. And it makes no sense, but we can't get any buy-in from the powers that be. That's why I think we need to get together and try and solve it ourselves.
What's been the role of the private sector in your successes? And what more should the private sector do?
Sure. Private sector in terms of privately practicing physicians, for example, are definitely close partners with us at El Puente. We consider every interaction that we have that requires an interpreter to actually have two clients, one being the limited English speaker and the other being the healthcare provider. In many cases, that healthcare provider is in private practice. We have been extremely fortunate to have worked very successfully with the privately practicing physicians in the sense that they will now not see a patient, for example, who needs an interpreter without having an interpreter present. That was absolutely not the case when we first started. So in terms of philosophically seeing a culture shift among the privately practicing physicians and them understanding how they partake in advocating for a successful system for the population that we serve, we've seen a great shift over the last decade. We're a nonprofit organization, and our services are free for a whole slew of different reasons, but to most of the privately practicing physicians, and we do request donations from them, and most are also very generous in that regard. So I would say that in terms of that limited piece of the private sector, we've seen great collaboration and partnership.
Julie, you can correct me if I'm wrong here, but I think that the private practitioners, certainly certain numbers of them, for the free clinic patients have been willing to see them and follow up, make sure somebody's there to look at their lab work. So along with the great work that the free clinic does, there is backup from the private practitioners.
That's absolutely the case. I've also been contacted. I spoke to a group of small business owners about how they could best educate their employees who are not eligible for health insurance through their small business on how to get signed up on the marketplace, how the business could potentially sign up on the shop marketplace, which is the marketplace for small businesses. And then our private providers, it's actually not unusual. Just yesterday, I got a call from a private provider who was like, I literally have 10 seconds, but can you tell me if this person is eligible? And the person was, and so I let her know how she could put that person in touch with a navigator. But that goes on a regular basis as well. I just want to add one thing on the mental health piece too, Lou, if that's okay. If we can circle back to your question, Becky. I'm fortunate in that I'm also doing a graduate program right now in healthcare administration. And what we're really seeing nationally is that behavioral health is being really worked into coordinated care for patients in a manner that we have never seen before. And when you look at kind of the national trends right now when it comes to care, it seems like behavioral health is becoming the hub of the wheel. And then these care coordinated teams are being built around behavioral health. And to a certain degree, we're actually running a program that's similar to that here at St. John's. We partnered with the University of Wyoming to run the Stanford Chronic Disease Self-Management Program, which is a really fabulous program. We just graduated 7 individuals from that program, and it really is looking at self-efficacy skills and self-empowerment to manage any kind of chronic condition in a better manner. I always say I would probably benefit from being part of this because it can be something as simple as stress, but it's really approaching these conditions from the behavioral health perspective and how individuals can better manage those conditions themselves.
2 questions, or a question and a comment. Talk a little bit about the mental health. Being that Wyoming has the highest suicide rate in the country, what are the 2 organizations, Mike Lou, doing in regards to suicide? And then more or less to Lou, in regards to what Julia identified as this donut or a hole in ACA, have we thought about something similar to the Community Foundation, but focused very specifically in helping people who can't afford?
Julia bugs me about this every week. We get into real big arguments about what can and cannot be done. Julia wants to do it all. I wish I could say, go do it all. We have talked about that, and the Community Foundation does help us with the prenatal entry program. It's such an economic, the cost of healthcare is so high to try and figure out a way you can have dollars come from the community to take care of people in the community. It's daunting because if you did what Julia wanted to do and took all these people who fell in the donut hole and gave them subsidized health insurance, all you're going to need with that small population is 1 or 2 people who get really sick, and all the money you have is gone. So it's not we've thought about it, but we don't really have a good answer. To go back on the suicide program, Wyoming is number 1, and we had this summer a real escalation with particularly teenagers, and we have come together with some ideas, had some speakers in to talk about suicide and some training in the school system, but do we have a really good plan? No, and I think this would fall into, this would be a priority if we did get somebody in to kind of coordinate mental health, that would be really high on the list of things they would need to do. It's not an easy problem at all.
Well, I hesitate to do this because I'm going to basically shoot a hole in my own plan that I would love to see happen. But part of making a plan happen is starting to understand some of the flaws in the plan. And so one of the flaws when it comes to the idea of a premium assistance program, ideally of course, what Lou and I have discussed is to a certain degree subsidizing premiums for this population on the marketplace itself, so that the actual true risk would be transferred over to the insurer on the marketplace. This has been done in other places, and in fact there have been some legal concerns around whether the risk is really being transferred over from the healthcare system to an insurer. And I am not an attorney, but I can appreciate that there is at least some credibility to that argument, that if a hospital were to actually subsidize the premiums for an individual to then be insured on the marketplace or with an insurer, then if that individual got really sick, then the insurer would be paying a very high amount, and the argument could be made they would be insured if it wasn't for the assistance. I hope that made sense. Feel free to ask more questions. And then I just want to say, in reference to the suicide issue, we recognize that it is an enormous issue that needs to be addressed here. The Wellness Department partnered with the Teton County Suicide Prevention Coalition. This last fall, we actually brought in one of the foremost experts on suicide postvention, which is basically how a community responds after suicide has occurred, and family and school districts. And had amazing participation in her efforts. I hope that we can do more things like that in greater partnership with our folks who are really on the front lines of that. And I was actually very honored to wrap suicide into the idea of what wellness is. A lot of people actually said to me, this isn't wellness, this is suicide. And I was like, no, suicide is absolutely a part of wellness. So.
I'd like to just follow up on the emphasis of Lou introduced in the president of the meeting here about the importance of behavior, sort of integrating it into medicine. And it seems to me that there is a distinction that's useful in that sort of two sides to this. One is real pathology. That is, people who either are a danger to themselves or to others, or who are sufficiently disorganized in terms of their mental status that they can't take care of themselves, can't hold a job, they can't do and this requires a level of professional involvement. And I think one of the problems that we have in Wyoming is particularly with a small and highly dispersed population, that the frequency of these problems is not high enough in some ways to have a group of healthcare professionals who can deal with it, and the problems of how you deal with that geographical dispersion, and the fact that there are too few mental health experts and practitioners in the state for a population is, I think, a real one and a serious one. The other is somewhat different, and I think it's more what Julie was talking about, and actually what she's been very successful with. And that is that a major part of wellness is how do we change our behaviors in all sorts of ways. And this is not something that affects a small number of people who have a severe pathology. This is something that's true for all of us. Trying to change behavior is one of those difficult problems we have. But for addictions, anybody who's ever tried to quit smoking cigarettes, for example, alcoholism, major problem, and directly at home with type 2 diabetes, where issues of diet, exercise, and some of these other things come in. And I would say that the strategies for dealing with those are somewhat different and the resources required. And although I'm sure we're a long way from being successful with that, I think some of the programs that you have run, Julie, out of the Wellness Center have been very successful on a small scale, and I would hope there would be an opportunity to do more, and maybe to talk about that. I think particularly with the minority population, or the propensity to type 2 diabetes, questions of and cultural changes in diets and all the rest, and cultural factors that influence behavior. These are really complicated and difficult questions, not in terms of getting resources, but actually how to go about changing people's behavior in an effective way. So I just want to make those comments. Thank you. Oh, all right.
I just want to respond to that. I think that was very well stated. And I would like to add that El Puente tends to be involved with, when it comes to attempted suicide, more than those who accomplish the task. And another area that is very closely related to what was just discussed is the lack that I see of overall support for families after an attempted suicide. And I think that's obviously a very critical concern, but related to other issues where behavioral change is required, in that we tend to respond very well to the acute and the moment of crisis. And then the ongoing 2-year-long higher support system necessary to keep the family on track, or to keep the pre-diabetic out of diabetes, is where we have a tendency to kind of fall off with our support system. And we are in the process of looking at what type of longer term systems we can develop to help with the longer term issues associated with chronic conditions, because obviously if someone has a chronic condition, chronic care and support is needed. So thank you for bringing those connections to light there for us. I think that's really helpful.
Brian?
So we all, it's very obvious that access to healthcare is a real problem. It's expensive, but I think Lou touched on something that I'd like your opinions on, and that is the extremely high cost of healthcare. Not just the high cost of insurance, but why does healthcare cost so much? And is somebody getting really rich here? And if so, is there anything that, I mean, does the healthcare industry, let's call it, need to look at their own behavior? I mean, I agree that the behavior of people affects our health. How is the healthcare industry behaving, in your opinion?
In a word.
How is it doing?
Badly. Is that the right word? No, we do have a huge problem with that, but let me tell you, and everybody, including when President Obama was running for office, he put a target on the backs of the healthcare insurance industry and said, they're the ones at fault. They're the ones that are making things so expensive. The truth be told is they're doing what any other business, for-profit business would do. They're making money according to the rules that were given them, and those rules go back to Washington. And we just have a set of rules that allows, when, the amount of money the pharmaceutical industry put into the election was really pretty, the lobbyists that sit in Washington, get rid of all those people and don't allow them to be there. But you've got to change the rules, because otherwise you're going to change the rules for the banks, and you're going to change the rules for the coal companies, or you're going to change the rules for the grocery store in town and put limits on them. In truth, the insurance industry has a 3 to 4% at best profit per year. Do you think the electric companies will get along on that? Do you think that the gas companies are getting along on that. So we have put up this kind of structure that says, here's where the problem is. The problem is us. It's us and who we elect and allow them to go to Washington and create these rules that really increase our cost of care. That's kind of where I would go. You know, a device company comes out and they have to pop through the FDA rules to get their device on, and they're going to charge, their device may have somebody tomorrow who's got that same device, it works a little bit better, and all that money they put in is sunk, and so they're going to try and get the money as quickly as they can. So it's a perverse system, it really is.
First of all, we are going to address suicide and suicide prevention at the Sacred Conversation on Guns, so please come, we're bringing in some good people. So I have to ask a question that is totally against my belief system. It is opposite what I think, but this is what I hear on the street. If you would stop giving free care to undocumented people and people without insurance, you would have more money. What's your obligation to those people as a hospital? Not my opinion.
Well, we certainly have a moral obligation to take care of anybody who walks in. And we have a federal law that says anybody walks in the door, we've got to take care of. That's not true of the private practitioner's office, but it is true of the hospital. So we have it both ways, that we do have to take care of people. But, you know, the problem with some of the comments that have come out of this legislative session about the ski bumps getting Obamacare, we don't see that. That's not who's coming in. And so we're hoping that if we can identify somebody early with their diabetes, get them into some preventive care, that they are going to cost the community less money. Unless you want to be Donald Trump and send everybody away, you have to take care of the people, and you're going to spend way more money by not taking care of them as they get sicker and sicker than you are if you can do something preventively. And you know, right now the ER is a place, but it's not the right place. So we should be doing everything we can to transfer that care to an even earlier point. And we are working with some state funds to maybe we can get some kind of a rural health clinic going here that would break down barriers for people being able to go comfortably to get care. We're all paying for it.
I think we have time for one more.
I just want to mention also something about suicide, because at the community resource center we give financial help. But sometimes when they come in and they ask for the rent or whatnot, they start telling you the story of what's going on. And then the parents say, you know, well, it's because my child tried to commit suicide and had to be airlifted to Salt Lake City, and now they don't have insurance, how much they have to pay for that. It's really, for me, it's a tragedy, a really big tragedy, because I've seen at least like 8 families that they come to us, and I'm not even a counselor. I'm not in the counseling center, it's just the financial part. But when I hear the responses of the moms, the way they treat these kids, I mean, I'm in shock. Because they don't know how to really, well, who knows how to deal with something like that? You're not really prepared. But they really blame it on the kids. They treat them very harshly. I wish there would be something that would be done for the whole family, because it's not only the parents. I can hear the other kids, you know, the brothers, sisters, you're creating the problem. So it's a very much more acute thing. So it's the family that needs that whole help. And I hope there would be something, like you said, wellness, prevention. That would be the best thing that we could do, and you know, to help everybody. Because just losing one child, I don't care, documented, undocumented, Latino, Russian, it's one life. Thank you.
Thank you, Carmina. For me, listening and participating and being involved in healthcare in the community and thinking about this theme of common good, I think what we've heard today is we're all in this together. and we all have to work towards resolving a lot of these issues. I want to say that I feel so fortunate to live in a community like this. We have so many resources and so many people that work together. I mean, you can tell just by listening to Vida and Julia, that come together to really solve these problems. And as Lou said, the healthcare national picture is still so complex. Lots of good things are happening, but we need to solve a lot of things locally. We'll be much better solving it locally. So please, stay involved in the conversations. Definitely making calls to your legislator, obviously. But get involved.